Ataxia. It's one of those signs that can be, well, pretty intimidating when you see it at the bedside, right? That uncoordinated movement can feel like a huge puzzle. But don't worry, this explainer is designed to be your practical, high-yield guide built specifically for psychiatry residents to help you get confident in approaching, evaluating, and really understanding what's going on. So let's dive in. All right, so here's our game plan. First, we'll nail down what ataxia actually is, and this is key for us, its connection to psychiatry. Then we'll get into how to find the lesion, I'll give you a bedside exam toolkit, we'll talk about figuring out the cause, and we'll finish up with some super high-yield clinical pearls you can take with you. Okay, so first things first. What is ataxia? When you boil it all down, it's a problem with the cerebellum. You can think of the cerebellum as the brain's master coordinator. And it's not just coordinating our movements. As we're about to see, it's also a major player in our thoughts and emotions. Yeah, so the cerebellum doesn't, initiate the movement. That's not its job. Its job is to be the quality control expert. It's the part that makes sure every movement is smooth, coordinated, and hits the mark. It's constantly taking in all the sensory information from your body and fine-tuning everything on the fly. We're talking about everything from walking a straight line to something as simple as reaching for your morning coffee. Okay, and this is where it gets really critical for us as psychiatrists. The cerebellum's job description is way bigger than just motor control. When there's damage here, you can get something called cerebellar cognitive affective syndrome. And what does that look like? Well, it can look a lot like things we see every day. Impaired working memory, a flat affect, even big personality changes. It's just a huge reminder that you can't separate the mind from movement. They're totally intertwined. All right, write this down, tattoo it on your brain, whatever you have to do. This is the fundamental rule for localizing a cerebellar lesion. The signs are almost always ipsilateral. That means same-sided. So a lesion in the right cerebellum causes symptoms on the right side of the body. Now you might be thinking, wait, doesn't everything cross? Well, most things do, but the cerebellar pathways are special. They actually double cross, so they end up right back where they started, controlling the same side of the body. So how do you actually spot these signs at the bedside? I want you to remember the A's, D's, and N's. It's a handy little trick. First up, dysmetria. This is that classic over or undershooting when you're trying to reach for something. Then there's, and this is a mouthful, dysdiadokinesia. Basically, it just means you can't do rapid alternating movements smoothly. Think trying to tap your hand back and forth really fast. Next, dysarthria. This isn't just slurred speech. It has a very particular scanning or staccato quality to it. And last but not least, nystagmus, those jerky eye movements. Specifically, we're looking for direction-changing nystagmus. All right, so now that we know what we're looking for, we get to put on our detective hats. The first big question is always, where is the lesion? And thankfully, the cerebellum has a really neat and tidy organization that helps us out. You can basically split it into two main parts. You've got the vermis right down the middle, and then the hemispheres on the sides. The vermis, being in the midline, controls the middle of your body, your trunk, and how you walk. The hemispheres, being on the sides, control the sides, your limbs. It's that simple. So a problem in the vermis gives you truncal ataxia, trouble sitting up straight, a wobbly gait. A lesion in a hemisphere, that's going to give you ataxia in the arm and leg on that same side. And you've all seen the classic example of this, even if you didn't realize it. Think about a patient with a history of chronic alcohol abuse. Alcohol just loves to damage the anterior vermis. And what do you get? You get that textbook picture, someone with a really severe, wide-based waddling gait. But you ask them to do the finger-to-nose test, and their arms are surprisingly steady. Why? Because it's a midline problem. Their core is ataxic, but their limbs are kind of spared. Now, this is super important to remember. Not all unsteadiness is coming from the cerebellum. You've got to be able to tell the difference. For instance, there's sensory ataxia. This is a problem with proprioception. Your sense of where your limbs are in space. The big giveaway? It gets way worse when the patient closes their eyes. Then you have vestibular ataxia, which almost always comes with a huge dose of vertigo, nausea, maybe even vomiting. But true, pure cerebellar ataxia, the patient is unsteady whether their eyes are open or closed. Vision doesn't help them much. Okay, theory is great, but let's get practical. How do we test for all this stuff at the bedside? The good news is you really don't need any fancy equipment. A few key maneuvers will tell you so much. For the finger-nose test, here's a pro tip. Make sure your target is far enough away that they have to fully extend their arm. That's what really brings out a subtle intention tremor. For the legs, the heel-to-shin or knee-heel test is your go-to. You'll often see the ataxia right away, just in the difficulty of getting the heel onto the opposite knee. And please, whatever you do, do not skip watching them walk. A normal walk and then a tandem, heel-to-toe walk. That tandem walk is incredibly sensitive. It'll pick up even very mild cerebellar issues. Okay, I'm going to pause here for a public service announcement because this is probably the most common point of confusion out there. The Romberg test is not, I repeat, not a cerebellar test. Remember what it is? Patient stands with their feet together and then they close their eyes. If they're pretty steady with their eyes open, but start to sway or fall when they close them, that's a positive Romberg, and that points to sensory ataxia. It's a test of proprioception, not the cerebellum. All right, so we figured out where the problem is. Now for the next big question, what is the lesion? And honestly, the single most powerful tool you have to figure this out is the timeline. Yeah, just thinking about the onset is so high yield. If the ataxia comes on in minutes to hours, you have to think vascular, a stroke or a hemorrhage until proven otherwise. End of story. Now, what if it's over hours to days? In our world, on the psychiatry service, your alarm bells should be screaming Wernicke's encephalopathy or medication toxicity. Think lithium, think phenytoin, and if it's been slowly getting worse over years, that's when you start to think about the chronic neurodegenerative stuff like NPH or MS. And of course, we have to talk about functional or psychogenic ataxia. Now, this is always a diagnosis of exclusion, but there are some classic clues you can look for. The gait is often, well, bizarre. It's called astasia abasia, which basically looks like they're walking on ice or lurching all over the place. But here's the kicker. They almost miraculously never actually fall. They'll lurch dramatically and then catch themselves at the last second. The symptoms can also be really inconsistent and often get way better if you can distract them. Whew, okay, we have covered a ton of ground. So let's wrap this up by boiling it all down to a few essential high-yield pearls that you can take with you. Pearl number 1, the localization rule of thumb. Seriously, if you walk away with only one thing today, make it this. Vermis is midline, so it causes midline problems, truncal and gait ataxia. Hemispheres are lateral, so they cause lateral problems, ipsilateral limb ataxia. That simple binary will get you 90% of the way. Okay, pearl number 2, and this one is a potential lifesaver. If you have a patient with acute vertigo and ataxia, you need to know about the HANS exam. It's a simple set of bedside eye movement tests, and get this. In the right hands, it is more sensitive for a posterior circulation stroke than an MRI in the first 24 to 48 hours. Let that sink in. More sensitive than an MRI. This is a powerful tool. So let's just end on this thought. The best way to think about the cerebellum is as the brain's great provider of smoothness. When it gets damaged, it's not just our movements that become clumsy, jerky, and uncoordinated. Our thoughts and our emotions can lose their fluidity too. And when you really grasp that, you start to see the whole patient, and you can truly start to bridge that gap between neurology and psychiatry. That's what this is all about.